attendings in the department. And today he's going to give us a presentation on severity of concussion. Theodore Hannah. Theodore, we can see your screen there. There we go. We can hear you now.
Appreciate it. So today I'll be discussing my work from the past 2 years on developing the first quantitative severity metric for concussion using the ImPACT neurocognitive test, and how we've used it to try to provide some possible answers to longstanding questions in the concussion field about certain high-risk groups. My mentors for these projects were Dr. Choudhri as well as Dr. Lovell, who's the co-creator of the ImPACT test. So just quickly, I'll provide some background on the current state of concussion severity grading and what the ImPACT test is, and I'll go over 3 of my papers. The first one where we developed the severity index, and the second and third where we applied it to high-risk populations to see if we could provide some insight into known differences in incidence and recovery in those populations. Then I'll briefly discuss where we want to go from here. So concussions are kind of notorious for varying widely from person to person or incident to incident in terms of the severity at the time of injury, which symptoms are most prominent, and then time needed to recover. There's also a lot of ambiguity in the diagnosis itself. As you can see, it's solely a clinical diagnosis with no minimum number of symptoms required and not even a single symptom that's always required to define the boundaries of what can constitute a concussion. Furthermore, the consensus statement says things like concussion has a rapid onset, but it can also take hours or days to develop, and recovery usually follows a sequential course, but it can also be prolonged. None of this is particularly helpful to patients who are suffering. And additionally, some former grading systems were similarly ambiguous. Specifically, these 3 classifications are the old classifications that I kind of grew up with. They're not really used anymore. They don't cover the majority of the symptoms asked on the current post-concussion symptom scale listed in the bottom left corner there. Many of those symptoms are much more common than amnesia or loss of consciousness, which dominate concussion grading scales. And there's also no neurocognitive component to these grading scales. These grades can't really be tracked over time to assess improvement or worsening of pathology, and the grade 1 concussion category is so broad, probably includes about 95% of concussions. I have to imagine it'd be pretty impossible to use them to meaningfully predict outcomes. There have been many neurocognitive assessments developed over the past 20 years to assess concussions, such as ImPACT. There's also Right Eye, the SCAT2, but none of them have really been used to quantify severity. There are multiple studies looking at simple versus complex concussion or normal versus protracted recovery length concussion. And these are generally defined similarly, with complex concussions or protracted recovery defined as those that don't resolve within 14 days, while simple concussions are those that do. And although many of these studies imply that they're proxies for concussion severity, they tend to avoid direct discussion of severity, and these definitions aren't all that useful as they really conflate severity with recovery. It's basically like if you ask for a grade on a subarachnoid hemorrhage, and instead of getting a Hunt Hessler modified Fisher grade, they tell you just wait 14 days and get back to you. Once again, it's just not super useful to patients who are suffering. So the studies I'll be presenting all use data collected from ImPACT tests. So I just want to give a brief overview of the test. The ImPACT test was created by Dr. Lovell and Dr. Joe Maroon in the early 90s. It's a computerized assessment of neurocognitive function and somatic symptoms. There are 5 main outcome measures: verbal memory, visual motor, reaction time, and a symptom score. These scores are calculated based on performance on various tests, such as the 2 shown at the top of the slide here. The symptom score is based on a self-ratings across 22 symptoms, each on a scale from 0 to 6. And those symptoms can be broken down into 4 clusters: migraine, cognitive, sleep, and neuropsychiatric. There are also measures of effort and understanding of the test, such as impulse control, and this is used to flag invalid tests to avoid misdiagnosing concussions. The test itself takes about 20 to 30 minutes to complete. Subjects with concussion are about 47 times more likely to have significant dysfunction on at least 2 of the 5 outcome measures. Prior exposure to the test has not been found to improve performance on the test, which mitigates some of the concern about practice effects, which are often present in neurocognitive testing paradigms. The bottom picture shows an example ImPACT test readout comparing a subject's baseline scores in green to the post-injury test in red. So next I'll go over how we created the severity index. So Dr. Choudhri was able to procure this large data set of ImPACT tests in 2019. We wound up with over 25,000 tests conducted over the past decade of student athletes ages 12 to 22 in Florida and Colorado. To create this severity index, we used 2,300 subjects that had a baseline test and suffered some sort of head injury necessitating initial concussion evaluation, which we refer to as PI1 in our papers, and then at least one subsequent follow-up test after the injury to help us assess recovery, and that's a PI2 test. Important definitions for this presentation are listed here. Definition of concussion for our purposes was at least 2 out of 5 ImPACT composite scores significantly deviated from baseline. Incidence was the number of PI1 tests meeting certain, or the criteria for concussion per person year. ImPACT baseline tests are considered accurate for up to 2 years. So patients with a baseline that were then lost to follow-up were given 1 patient year in accordance with CDC guidelines. Severity was defined as the value generated by the severity index, and recovery from concussion was a return to less than 2 out of 5 ImPACT scores significantly deviated from baseline. Okay, so in the center is a set of equations that defines our severity index. On the right upper corner are the reliable change indices for each composite score upon which our index is based. These indices are considered the upper limits of just normal variation in test scores for a completely healthy individual taking the ImPACT twice. So in order for a result to be considered abnormal on post-injury testing, the change in score must be greater than the reliable change index at the 80% confidence intervals, that middle column of numbers that's highlighted. And we refer to that as SDIF in our set of equations. Along the bottom is the calculator we included in our publication to make it much more easy for providers to calculate the severity index for their patients by just plugging the 5 scores for the baseline test and 5 scores from the post-injury test into the Excel file. So to calculate the severity index in equation 1, we calculate the difference between the post-injury score and the baseline score. For some composite scores, higher numbers are worse, whereas for other lower numbers are worse. So you just take the absolute value of the change. A crucial caveat that's not explicit in the equation is that if the subject improved on a composite score, it's ascribed a value of 0 in equation 2. But if they performed worse, then you have to compare the absolute value of the change from baseline to the SDIF for that composite score. If the change in score is less than FDIF, then it's also ascribed a value of 0, whereas if the change is greater than SDIF, then it's ascribed a value of that absolute difference. And then finally, in equation 3, you have to standardize the value produced in equation 2 for each of the composite scores by its respective SDIF, so that in theory, at least, each composite score can contribute equally to the severity index. And then the sum of those standardized values is your severity index. So just for example, for processing speed, this subject performed 10 points worse on his post-injury 1 test. He went from 40 to 30. The SDIF for processing speed is about 5. It's 4.98. So they get about 2 points towards the total SI for that. And then they also had significant deviations in verbal memory reaction time. A symptom score that end up totaling an SI of 20 or 12.5, which is fairly high. And then obviously you can continue to calculate the severity index at each subsequent test, tracking recovery over time. So we found that SI at initial presentation, so PI1, correlated very well with SI at subsequent follow-up tests. And as a direct corollary, also correlated with the likelihood they still met concussion criteria at their next follow-up. We then binned SI into 4 groups based on the initial SI, and it showed significant differences in recovery time, with median recovery time increasing with increasing SI. And these are all very reassuring results for a severity metric, but they shouldn't come as a surprise. Importantly, we also saw that individual composite scores in each symptom cluster at follow-up correlated strongly with initial severity. So it's not just one composite score that's driving these results, all of the components are working in the same direction. And then when we ran a multivariable regression to evaluate the association between SI and recovery while controlling for other factors that might affect recovery, we found that SI increased the likelihood that a patient would still meet concussion criteria at their follow-up visit. SI increased the AUC of this model from 0.53 to 0.70, so it does provide a significant improvement, but there's still lots of room for improving the predictive value of this metric. It just goes to show that it's very difficult to predict concussion recovery in general. So that's our severity metric, and then we kind of wanted to see if there's any way we could try to push the field forward. So there are a few groups that have historically been recognized as having either greater concussion incidence, more severe symptoms, or longer recovery. And gender and a history of concussion are two that leapt to my mind. And so that was the first thing we tried, was applying the SI to look at gender differences. So the current literature has shown that females have higher concussion incidence and take longer to recover, as noted in the bottom box in the top right, or the box in the top right there. So to investigate gender differences in severity, we split our data along gender lines. Important to note that males had higher rates of ADHD and had a way higher percentage playing football, and these two variables are highly associated with increased concussion incidence. So our original unadjusted analyses are biased against females demonstrating a higher incidence of concussion, which is the expected result. There are also gender differences in every baseline composite score, which has been seen throughout the literature. Females consistently report more symptoms, but have better verbal memory, processing speed, and reaction time, whereas males have better visual memory. Fortunately, because ImPACT test compares the subject's own baseline, these differences aren't as concerning in terms of biasing our results. So just to recap some background information on all the organizations from which our data set was collected, followed the same protocol with regards to when subjects were referred for post-injury impact testing. The subjects need to have some sort of head trauma that resulted in suspicion for concussion in order to be sent for testing at all. So those subjects are included in the top half of the table, which we called head trauma, and then to be included in the bottom half, the subject needed to meet our criteria for concussion, which was 2 out of 5 composite scores significantly deviate from baseline. So in our unadjusted analysis, we found no difference in incidence for either head trauma nor concussion. Females did have higher severity in the head trauma analysis, but not in the concussion group. In terms of recovery, unadjusted analysis indicated that females with concussion took significantly longer to recover than males. The event in these analyses is recovery from concussion. So a hazard ratio less than 1 indicates females are less likely to have recovered from concussion, as you can see in the Kaplan-Meier plot here. Once we did control for differences between the cohorts, we found that females did in fact have increased likelihood of concussion as we expected. Their concussions were also found to be more severe as measured by our severity index. And intriguingly, once we actually controlled for initial concussion severity, the difference in recovery time completely disappeared. Because no one else has ever had a metric to assess concussion severity, no other study has ever controlled for concussion severity in their analysis of gender differences in recovery time. And so unfortunately, although our results do not provide insight into why females have higher concussion incidence, they do allow us to hypothesize that perhaps females don't necessarily take longer to recover from concussion as previously thought, but rather tend to be recovering from more severe concussions. So future studies evaluating recovery patterns with more frequent serial testing in patients with similar severity concussions may be necessary to evaluate gender differences in recovery time. So next, we use the same framework to evaluate another high-risk group, subjects with a history of prior concussion. So patients with a history of prior concussion are known to have a higher future concussion incidence. Well-controlled prospective studies have provided conflicting results when it comes to whether patients with a history of recurrent concussion take longer to recover from subsequent injuries. Some have shown an increase in recovery length, while others have shown no difference at all. We split our data set into those with a history of at least 2 prior concussions and then a control group who reported no prior concussions, and excluded all subjects reporting 1 prior concussion. Again, there were unsurprising but important demographic differences between the groups that we'll control for in our adjusted analyses. And just to address the discrepancy in naming here, the reviewers of this article took issue with using ImPACT results to define concussion, which is a reasonable critique. So we use the term significant neurocognitive dysfunction instead. But just to be clear, it's measuring the exact same thing as we did in the 2 prior studies. Here we saw that subjects with a history of concussion showed increased incidence of concussion, almost a 2-fold increase, but were actually found to have lower concussion severity. In terms of recovery, there was no difference, as shown in the Kaplan-Meier there. In our adjusted analyses, there were no changes to the results. Subjects with a history of concussion had higher concussion incidence, but decreased concussion severity. No difference in recovery was seen, even when controlling for the lower severity in the history of concussion group. What's even more interesting is that the more lenient we made the criteria for concussion, the more the odds ratio for incidence increased. So it went from 1.9 when we required 2 out of 5 deviations, then increased to 2.7 when we required 1 out of 5 deviations, and then it went all the way up to 3.7 when we considered all head traumas being a concussion. Given these results, we now hypothesize that part of the reason subjects with a history of concussion have increased risk of future concussion is that they're more likely to be aware of what a concussion feels like and more likely to disclose such symptoms to the medical professionals referring them for testing. whereas those who have never had a concussion before might require more severe symptoms to recognize that something's wrong. The result is that we're much more likely to catch these lower severity concussion in those with a history of concussion than those without. Importantly, we do not contend that this explains all of the increased risk, just that it may be a previously overlooked component based on our analyses. So overall, the Severity Index we've developed promises to provide patients and their healthcare providers with a single intuitive value that characterizes their concussion severity in a quantifiable, trackable, and modestly predictive manner. This is something that the field has been lacking and in need of for quite some time. We've also been able to leverage the Severity Index to investigate reported differences in concussion incidence and recovery in a couple of high-risk populations, generating new hypotheses to explain these differences, which should help steer future studies. Of course, our data is not without limitations. Specifically, it's a retrospective data set with incomplete information and a lack of standardization of post-injury testing dates, which must limit our confidence in the accuracy of our analyses. Therefore, we'd really like to work with ImPACT or just patient providers to evaluate the utility of the Severity Index in a prospective manner to determine its true clinical value. So I just want to thank Dr. Choudhri and Dr. Lovell for the opportunity to work on these novel projects with them, as well as my co-authors on all of the concussion projects we generated over the past 2 years, especially Adam Lee and Dr. Schopper. I'd also like to thank my other research mentors during my time at Sinai, including Dr. Zoe, Dr. Kellner, and Dr. Caridi, who've all helped me improve my ability to conduct research and write papers. I'd like to thank the Neurosurgery Leadership Group here at Mount Sinai for putting together SUBI and giving me this opportunity to present. And I'm happy to take any questions.
Thank you, Theo. I'd like to make a quick comment. First of all, congratulations on your work and this. When I saw your presenting, I know that there's probably a half a dozen things in our lab alone that you could present on, and this is one area that you've done work. It's quite impressive. The head injury, we're first author on a JNS pediatrics, head trauma already getting some traction with citation. So it's amazing how, despite all the interest the country has in concussions, a relatively small, mostly unfunded group of researchers can there's some series that define a new metric to define severity, which hasn't been done, as well as to really, do some of the largest studies out there on gender and other topics that are out there. So congratulations on your work on this and others. Look forward to seeing, it's very obvious that you have a depth of knowledge. Anyone who has met you, but especially on data and programming and other things, it's really helped our group. So thank you for all that, Brooke.
Thanks, Dr. Choudhri.
Theodore, I have a question for you. It's a
Yes.
beautiful set of papers and consistent effort, very impressive. I was wondering why the consistent observation that women have more severe head trauma. And then in the second part of your talk, you provided something that might give some insight in that people who are more aware of the symptoms report more severe head trauma. Do you think that could explain why there's a gender difference to begin with? Maybe the men are just so foggy. The men are just so foggy that we don't even realize we've had the head trauma.
Yeah,
I'm joking, but I'm not joking.
Yeah, no, it's a serious consideration, and something I think I've tried to find ways to kind of control for that. I think we do find, I've done the analysis where I leave the symptoms score out and they still have more severe concussion, so I'm not as concerned. But it's certainly a problem when your definition of concussion is 2 out of 5 symptom scores, and you know that females are more likely to report symptoms. The other thing that controls against that a little bit is that it's based on your baseline score to your post-injury. So if females will report more symptoms at baseline, making it more difficult to actually be considered significant, for there to be considered a significant difference in that change in symptom score. So that also controls against it a little bit, but it is something I worry about.
Interesting. Thank you.
Theodore, is there any objective measure of severity, such as helmet force?
Yeah, they've tried to use those devices. I'm not familiar with all of the accelerometer data. I don't think, I don't know that it correlates with clinical severity. So it would be interesting to see whether it does. I'm not sure that anyone has done it since, we've never had such a severity metric before. But it would be interesting to see if the velocity or the impact correlates well with the clinical severity.
Just comment, because I feel like I've heard recently some reports of NFL players force when getting hit. I feel like I've seen a few comments on that.
Yeah,
and we're not able to hear you.
Sorry, can you hear me?
Can you hear me?
We can hear you. Yes, we can.
Yeah, so the sensor data has been widely panned as unhelpful. There's some interesting work done on biomarkers, but at this point, it's still very hard to get accurate data. Saliva hasn't panned out. Blood is not easy to get. CSF is very hard to get. So I think at this point, neurocognitive and severities indices related to that is as good as we get. But without good imaging, without other things, mild traumatic brain injury is very hard to study, as you point out.